Welcome to the Brain Tumor Foundation InfoCon. On behalf of Dr. Oyesiku, it gives me enormous pleasure to have a brain tumor InfoCon today. I am Soma Sengupta, Professor of Neurology and Vice Chair of Research in Neurosurgery, Division Chief of Adult Neuro-oncology at the University of North Carolina, Chapel Hill. The Brain Tumor Foundation was founded in 1998 by the distinguished Dr. Patrick J. Kelly. The mission of the BTF is to raise awareness among medical professionals and the public about the need for the early detection of brain tumors while continuing to offer support groups, medical referrals, and informational events. Bringing hope for tomorrow is a motto. BTF advocates for being proactive, for example, in early detection. It's supportive to patients, caregivers, focusing on children and AYAs while heralding innovation. In terms of the landscape of neuro-oncology trials, 2024 saw the publication of 2 CAR-T phase 1 trials showing promise in recurrent GBM. Dr. Adam Sonnabend and colleagues published an elegant study looking at low-frequency pulsed ultrasound in aiding the delivery of doxorubicin in gliomas. On the personalized vaccine front, Dr. Biskup and colleagues published a series of 173 GBM patients with a personalized neoantigen-derived peptide vaccine, highlighting 2 ongoing GBM clinical trials, the IMVAX IGV-001 and the Survaxum trials, and there's more to be seen in these spaces. But without further ado, I would like to introduce Dr. Ejinadum. Dr. Nadum is the Daniel Lewis Barrow Endowed Chair and Professor in the Department of Neurosurgery at Emory University School of Medicine. He's a fellowship-trained and board-certified neurosurgical oncologist, and Dr. Nadum's clinical specialty is the surgical management of brain and spinal cord tumors. He's particularly interested in the safe resection of malignant tumors located in the eloquent areas of the brain and brainstem and spinal cord. He is a member of the Cancer Immunology Research Program at the Winship Cancer Institute of Emory University. He holds numerous positions in national and international medical societies. He is the scientific program chair and member at large for the Congress of Neurological Surgeons, co-founder of the Society for Neuro-oncology Sub-Saharan Africa, bylaws chair of the Joint Tumor Section of the American Association of Neurological Surgeons and Congress of Neurological Surgeons. And on May 10th of this year, Dr. Nadum was appointed by President Biden to the National Cancer Advisory Board, which complements the Cancer Moonshot and provides guidance to the NCI director in the setting of the course for the National Cancer Research Program. And without further ado, Dr. Nadum, I hand it over to you to talk about cytokine microdialysis.
Okay, well, next time I'm going to have to send you all a shorter bio so I have more time to talk about the science. But thank you very much for that generous introduction. Hopefully you all can see my screen now. But going to talk a little bit about a clinical trial that I have been working on. Shar, is my screen is showing? Presentation showing, great, okay.
Yeah.
That I'm hoping will provide us some better information on how our treatments are working or not. Dr. Sengupta's introduction, she gave some of the more promising treatments that we've had. I'm going to start actually by talking about some of the things that haven't worked so well and try to explain why they haven't and how I think we can move forward to make immune therapy successful where it hasn't been for brain tumors in the past. I have a few disclosures, none of which are relevant to this particular talk. I don't that this particular audience doesn't need to be introduced to glioblastoma, a very aggressive tumor, which is very difficult to treat. And as a surgeon, as you see, I've operated today. I'm very proud of what we are able to do surgically for patients. And this is just a quick example of one of the surgeries I would consider to be one of the more technically challenging types of surgeries. which is an insular glioblastoma where you have a tumor that's quite deep in the brain. So you can see here that in order to get to this lesion, I actually have to separate two lobes of the brain, the frontal lobe and the temporal lobe, and then dissect past several large blood vessels down to what is the very red and angry tumor. And so we spend a lot of time having to disconnect these tumors from the blood vessels that are overlying them, and they're quite bloody. And at the same time, I can't just cut all those blood vessels on top of the tumor because,
Excuse me, Dr. Nadoom.
yes.
Can you put your slides on presentation mode?
Oh goodness. Okay, let me try if I share from a different, 1 second. Stop sharing here. I'll try one more time to share the appropriate screen. Let's see here. Are you guys seeing the video now?
Yes.
Okay, great. So this is what I was trying to show before. Sorry, this is that deep tumor I was talking about. So this is, again, me just trying to dissect the frontal lobe from the temporal lobe here, so that I can then expose the red and angry tumor below. As we're doing that, you can see how different it looks from the more normal brain that's more superficial. But again, here you can see the bleeding that's coming from the blood vessel overlying this lesion in the insular cortex. And we have to move quite carefully and disconnect the tumor from those blood vessels because those blood vessels do supply the normal brain. So you can see here that we're now close to having skeletonized the blood vessels, but I'm still trying to take a few more tributaries that are supplying that tumor. Now you can see that skeletonized blood vessel there, and I'm working around that blood vessel to get more of the tumor out. And so again, this takes a long time. It's several hours before we start to get to what looks like more normal appearing white matter underneath that tumor. So you can see that looks a little bit more normal. So we're shaving those last few layers of cells away from the tumor. Now just checking with the neurostimulator to make sure I'm not too close to the motor pathways. Once I've determined that that's safe, I'll keep resecting now with the ultrasonic aspirator here, so that I can gently shave just a little bit more of the tumor away. Once I'm satisfied we've had a good resection, we wash everything back out. And you can now see that on the MRI, what was a big lesion there almost looks like a normal MRI after the surgery. So you would think that having spent all this time, we make a very big impact on patients' lives, and we do. But unfortunately, this is that same patient 16 months later. And so that's why someone is myself, I'm a neurosurgeon scientist, and while I do spend a lot of time operating on patients, I know it's critically important that we come up with new treatments. And part of that is looking at treatments that have been successful in other cancers. So there's this concept of checkpoint inhibition. It's something you may have seen actually won the Nobel Prize not that long ago. And it's the idea that we can give antibodies that will block the body's normal pathways to shut down the immune system so that immune cells can stay active longer and hopefully attack brain tumors and tumors broadly. And so again, normally when you have an infection or something, you don't want the immune system to stay revved up forever. So there is a normal break to stop the immune system from being active. But what happens is brain tumors have figured out ways that they can turn on the brake on the immune cell and keep the immune cell from being able to attack the glioblastoma. And again, these checkpoint inhibitors block those immune pathways. It's a double negative. They block the brake, they take the brakes off and allow the immune system to work more actively. And so we thought these would be very successful for glioblastoma, but unfortunately we found in some early trials that at least single agent checkpoint inhibitors were not working for glioblastoma. And a lot of people are trying to figure out why that might be the case. I'll skip over some of this preclinical data. But part of that came down to trying to figure out when these treatments were working or not. And the best way that we have for glioblastoma, because this is not a melanoma where I can take out a bunch of different melanomas while a patient's getting treated and see what's happening to the immune system in the tumor, we use imaging. So we do MRIs and we try and glean from the MRIs whether a patient is having a recurrence, meaning that the treatment's failed, or whether they're having an inflammatory response, which might mean that the immune system, again, which normally fights bacteria and viruses, is actually actively fighting a tumor. So this is an example I like to show where I have two patients, both of whom were on a checkpoint inhibitor trial, both of whom ended up having a right temporal lesion that developed after they'd been on treatment. And when I look at these two scans, I really can't tell very well which one might be a recurrence of a tumor and which one might be an inflammatory response that suggests that the immune therapy was working. But you find that patient one actually does have a successful response to therapy, where we've taken the brakes off the immune system and there are a lot of immune cells attacking the tumor, whereas the patient on the right did have a recurrence of their tumor where there were not a lot of active immune cells. So I wanted to come up with a study that was going to give us a new way of figuring out directly from the brain whether an immune treatment was working or not. And we decided to use this concept of cytokine microdialysis. So these are these microdialysis catheters. They are catheters with very thin tips that you can place safely into the brain without causing any bleeding or infection. And you're actually able to pull out the signals that the immune system uses to communicate directly from the brain, from the tumor and the brain around the tumor, so that over every 6 hours, you can get a sampling of, hey, does it look like we're getting more inflammation and that the immune system is working or not? And so we took patients who were going to have a resection of a tumor that had come back, a glioblastoma that had come back, at least it looked like on imaging it had come back. We did a biopsy to confirm the tumor had come back. We placed one of these catheters in the brain. Again, this is kind of what it looks like. There's a gold tip that you can see on CT scan. One into the contrast enhancing tumor that's bright on MRI, one in the brain around that contrast enhancing tumor. We then gave them one dose of one of those checkpoint inhibitors, the immune therapies that take the brakes off the immune system, and then we took the tumor out on day 8. In the meantime, again, we did that biopsy, so we had tissue before treatment. We placed a lumbar drain that allowed us to sample cerebral spinal fluid that bathes the brain and the spinal cord to see what changes in the immune system were there. We got baseline blood that we took every day as well. And then those microdialysis catheters I mentioned that we sample every 6 hours. 2 days after the biopsy, to allow the immune system to calm down after the biopsy, we gave them one dose of immune therapy, and then we took the tumors out on day 8. And then we continue to treat the patients, not just with the nivolumab, which targets one checkpoint inhibitor, but with a different checkpoint inhibitor as well, so that combination will hopefully treat the patients a little bit better. So these are just a couple images of me in the operating room, putting this into practice, where we had stereotactically guided our biopsy needle down to confirm that a patient had recurrence, and then passed a rigid guide to that tumor, put the soft catheter in place, and then allowed us to sample these tumors over time while we treated these patients with our best guess at the immune therapy that would work well for these patients. This was a small pilot study. I think small pilot studies are important because many small pilot studies allow us to learn a lot of things about how treatments are working or not, as opposed to just doing big studies where we might not get the right answers about what's happening with the drugs or not. So we enrolled a total of 23 patients in the trial, 10 who completed the study procedures. And we've started to get some information from those patients showing that we are in fact able to show cytokine differences and inflammation from the patients that's different from after treatment than before, and that the catheters are actually showing us that we can measure something that we wouldn't be able to measure in a different way. And so with that, I'll close basically just saying that, checkpoint inhibition, which is a therapy that's already FDA approved, is something that may still yet be fruitful for patients, but we do need to measure in a better way the responses to therapy so we can figure out what options to take next. That's it.
Thank you very much, Dr. Nadim. We're going to leave questions till the end of the session. And with that, I would like to introduce our next speaker. It gives me enormous pleasure to introduce Dr. Yasmeen Rauf. She is my colleague at the University of North Carolina, Chapel Hill, and she's an assistant professor of neurology and neurosurgery there. She did her neurology residency at The Ohio State University and neuro-oncology fellowship at the Cleveland Clinic. Her main area of clinical interest is glioblastoma. Her research interests include finding newer treatments for glioblastoma, and her current focus of research is CAR-T for glioblastoma, and she runs a phase 1 trial at UNC. The title of Dr. Rauf's presentation is CAR-T against B7H3 for glioblastoma. Thank you, Dr. Rauf.
Thank you, Dr. Sengupta, for your kind introduction. I'm going to be talking about CAR-T against B7H3 for GBM. These are my disclosures. We don't need an introduction to glioblastoma, but since this is being recorded and I know we have family members that are listening to our talk, I'll just briefly mention that GBM is the most aggressive and primary brain tumor in adults. Survival is extremely poor. Average life expectancy is 15 to 18 months for patients that undergo resection, radiation, and chemotherapy. Survival has remained unchanged since 2005. Recurrent glioblastoma is defined as a progressive disease that after initial treatment with radiation, with or without chemotherapy, the median survival of patients with first recurrence of GBM is 8 to 9 months. Bevacizumab and tumor treating fields are the only FDA-approved treatments for recurrent GBM. And I'm going to talk about our phase 1 clinical trial using CAR-T for recurrent GBM at UNC Chapel Hill. So what is CAR-T immunotherapy? CAR-T is a process that involves extracting specific immune cells from patients, engineering the cells in the lab to identify tumor cells displaying a specific molecular target, and then reinfusing the cells to fight a patient's cancer. And how does this CAR-T work? So modified and inactive viruses or mRNA are used to change genetic information in the patient's own T cells. T cells are programmed so they now have a chimeric antigen receptor specific to the patient's cancer. Millions of CAR-Ts are grown in lab. The new receptor enables them to latch on the patient-specific antigen on the tumor cells and destroy them. Here is a cartoon. We have a normal T cell, and we have a tumor cell that has an antigen. And the way they are right now, the T cell is not going to identify this tumor cell as something that it needs to target or kill. So viral DNA insertion is used that enables the expression of chimeric antigen receptors. These chimeric antigen receptors enable the T cells to recognize tumor cell antigen as foreign. CAR-T cells then multiply and release cytokines. That leads to tumor cell death or apoptosis. The first reports of CAR-T for CNS tumors came out from City of Hope, a 50-year-old patient with a history of multifocal glioblastoma was treated with chimeric antigen receptor T cells on second progression. They used their CAR-T cells against the anti-interleukin 13R alpha 2 receptor, and this was administered both locally into the surgical cavity and intraventricularly. This patient had a transient complete response that lasted for about 7.5 months. Several other targets for CAR-Ts are under investigation in different parts of the country. So why B7H3 as a target for CAR-T? We know that B7H3 is highly expressed in most solid tumors. This was assessed by evaluating the B7H3 mRNA expression in the Cancer Genome Atlas dataset that showed 77% of GBM samples had a high expression of B7H3. But what is extremely important is what you see here, that it is highly expressed in GBM cells, but is not expressed by normal brain tissue. And therefore, we think it's safe for this patient population. So why at the UNC Lineberger Cancer Center? The University of North Carolina Lineberger is one of the few select academic centers in the United States with the scientific, technical, and clinical capabilities to identify new tumor targets and manufacture and infuse novel CAR-T immunotherapy on campus. So the CAR-T cells that we infuse in our patients are manufactured on our UNC campus here at Chapel Hill. How do we manufacture CAR-T? We collect 30 ml from our patients, 30 ml of blood from our patients. We isolate T cells. We then use messenger RNA to transfer DNA information into the T cells that instructs the T cells to produce a chimeric antigen receptor on its surface. The result is a CAR T cell that is designed to recognize and attack cancer cells. Our researchers then use growth factors to spur the CAR T cells to multiply by millions. This is then tested for functionality, sterility, and then just frozen for whenever we need it next for our patients. Once patient is ready to get CAR T cells, an Ommaya reservoir is placed, and CAR T cells are given via the Ommaya reservoir to these patients. This is it's a phase 1 study, single center study to determine the safety of escalating doses of B7H3 CARs administered via the intraventricular infusion to adult subjects with recurrent or refractory glioblastoma. Eligible subjects receive up to 3 weekly infusions of CAR B7H3 cells and are followed for toxicities from the time of first infusion for a few weeks. So basically, once we confirm that the patient has recurrent glioblastoma, they come in for consents and screening. They have another visit for cell procurement. And once we have confirmation that the CAR T cells are manufactured, they come in for the Ommaya placement. And a few days later, they get their first infusion of CAR T cells. Just to conclude, just a quick slide on vision for the future. We are really excited about this clinical trial here at UNC, but we are also in the future looking at using focused ultrasound technology to see if it increases the delivery of CAR T cells in the brain, to use focused ultrasound technology to immune modulate the brain tumor before CAR T therapy. And my pediatric neuro-oncology colleagues are looking at other targets like GD2 for pediatric brain tumors. With that, I thank you all, and I thank all my colleagues at UNC, especially Dr. Dory, Dr. Sawaldo, Dr. Higgins, Anne and Catherine, who were really important to this entire process.
Thank you, Dr. Rauf. And with that, I would like to introduce Dr. Vibhor Krishna. He's a board-certified neurosurgeon specializing in functional neurosurgery. He currently holds the position of Associate Professor and Vice Chair of Neurological Surgery at the University of North Carolina, Chapel Hill. As a surgeon scientist, he has worked in the development of focused ultrasound technology to treat neurological disorders. He leads an NIH-sponsored research program to optimize the technique of focused ultrasound ablation. His research has catalyzed key advancements, including the launch of a phase 1 clinical trial of focused ultrasound in patients with treatment-refractory epilepsy, which has yielded promising initial results. He was deeply involved with the phase 2 and 3 multicenter trials that secured FDA approval for treating Parkinson's disease with focused ultrasound. And his work, along with other investigators, was published recently in the New England Journal of Medicine. With that, I would like to welcome Dr. Krishna. And he will be talking today about emerging applications of focused ultrasound for brain tumors.
Thank you, Dr. Sengupta, for the kind introduction. And thank you for this opportunity from the Brain Tumor Foundation to connect with patients and their family members about the advances in diagnosis and treatment of brain tumors. It's a fantastic panel, and I'm grateful to be a part of it. I'm going to be talking about focused ultrasound to aid the diagnosis and treatment in brain tumors. And the two main questions that I'm trying to answer here are, what is focused ultrasound and how is focused ultrasound relevant in the care for patients with brain tumors? And so focused ultrasound equipment looks something like this. You can see that there is an MRI machine in the background, which provides the guidance and a ultrasound transducer is mounted on the MRI table. And that's how the magic happens with focused ultrasound. It's an incisionless technology that uses sound waves. So these are waves in very specific frequency and allows you to target and treat very specific areas in the brain. This is very precise, and MRI then allows you to monitor in real time what you're doing in your treatment. This is FDA approved to treat several neurological disorders, including essential tremor and Parkinson's disease, and several other indications such as pain, epilepsy, and such are being investigated currently in various centers. And so I want to give folks a flavor of how this treatment looks like. And so this is a patient that we recently treated, a 70-year-old patient who has a 20-year history of tremor, which is progressively worsening over time. Their family members had tremors as well, which helps us establish the diagnosis to be essential tremor. And they were finding it difficult to do basic things that we take for granted in our day-to-day life, like eating food, buttoning the shirt, typing, and most important for them, playing music. So this patient is a musician, and because of the tremors, they had a hard time playing music. They were taking medications as needed, but as you can imagine, it was not that effective. And so our patient underwent focused ultrasound ablation at UNC, and this is how the treatment looks like. This is an MRI of the brain, shown here in various shades of gray. And I'd like to center your attention towards the center of this picture where you see a target type of lesion. This is what focused ultrasound ablation looks like on MRI. And you could achieve this without opening the skin or drilling holes in the skull, or without even touching patient's head either. And I'd like to play a video for you as to impress upon the audience the profound impact of this technology in treatment of patients with neurological disorders.
Dr. Krishna, there's no sound.
Are you able to hear the sound now or no?
Can you press play so I can?
Okay.
No.
Okay. That's.
I think most.
Is it better now?
Perfect.
Was that I was able to play the guitar, and I had not done that in years. My wife, who I've known now for about 14 years, had never heard me play the guitar. The first thing I did, grabbed a guitar and played. And it's like, my gosh, I'm playing like I'm 25. Yelled to my wife, said, come here. And I was just so excited. I mean, like, even now it's still kind of some chills. There are like tears coming down my eyes. And I said, I'm going to play a song. And I played a couple of songs. And it was like just such a magical moment of restoration. Of like I said.
So this is the focused ultrasound technology. The next question we want to address is, how is focused ultrasound relevant for brain tumors? And so this brings us to this focal concept of blood-brain barrier, which is a protective barrier that prevents toxins and infectious agents to enter into the brain, protects the brain during its development and afterwards. But it also acts as a barrier in preventing medications from reaching brain effectively, but also preventing materials from the brain to leak out into the blood. And so it reduces the to and fro traffic from the brain into the blood. And what focused ultrasound is able to do, focused ultrasound is, this is how the blood-brain barrier looks like, and focused ultrasound is able to temporarily open the blood-brain barrier for us to then do various things. And one of those includes a concept called liquid biopsy. And so there is emphasis in the brain tumor space of detecting these tumors early, monitoring these tumors as the biology changes over time, and monitor the response of treatment on these tumors. And so using ultrasound to open blood-brain barrier, then you can detect something called as cell-free DNA into the blood. And this analysis from the DNA obtained from the tumors then can allow you to monitor these tumors over time and monitor the treatment response. The other thing potentially that focused ultrasound can be leveraged is to improve the delivery of drugs into the tumor itself. We call this targeted drug delivery. And so this involves using microbubbles to open the blood-brain barrier and deliver therapeutics directly to the brain. And this is how it looks like. There is a video that shows that the blood vessel has a blood-brain barrier that's intact. We inject microbubbles into the circulation and shine ultrasound on it. And this causes the bubbles to resonate, allows to mechanically open the blood-brain barrier and delivery of therapeutics and collection of the cell-free DNA. So the last few slides, what I'd like to do is to talk to you about the trial that we have at UNC as a part of a multi-center trial called the Liberate trial, or BT15. This is a pivotal multi-center trial that's looking at the safety and effectiveness of doing a liquid biopsy in subjects who have glioblastoma. So it's a prospective study, and we are screening individuals with suspected glioblastoma who would then schedule to undergo surgery 4 weeks after the liquid biopsy and understand whether we get safely and effectively the cell-free DNA into the blood, and be able to then characterize how these tumors look like and compare it to the actual biopsy that's done after the surgery. And there are a few visits that are involved with this study. First visit is the screening and the enrollment visit. Then the next visit is the BBB disruption or the liquid biopsy. And then we do a safety check, and patients then undergo standard of care resection that Dr. Najim earlier showed, similar to that. And then tissues are collected, and then we compare these in the biopsy versus the liquid biopsy obtained with focused ultrasound. So this is my last slide, and I look forward to answering questions that you may have later on.
Thank you very much, Dr. Krishna. I would like to introduce our final speaker this evening, Dr. Dominique Higgins, who is an assistant professor in the Department of Neurosurgery at the University of North Carolina, Chapel Hill, and he specializes in neurosurgical oncology in the treatment of brain tumors. He completed a dual MD-PhD program at the Mayo Clinic College of Medicine, and while he was at the Mayo, he focused on tumors and completed his PhD thesis on glioblastoma stem cells. He went on to complete his residency training in neurosurgery at Columbia University's Neurological Institute of New York. He also completed a brain tumor fellowship at the University of Miami with an emphasis on minimally invasive open and endoscopic surgical treatments for brain tumors. His research focus is the treatment of malignant brain tumors, including glioblastoma, and today he will talk to us about targeting metabolism in glioblastoma.
Thank you, Dr. Sengupta, for the kind introduction, and the Brain Tumor Foundation for the invitation and the opportunity to speak to the patients and families about some of the things that we're working on. It's exciting to hear about the advances that we have in progress for treatment of glioblastoma. And so I'll share with you today some of the work that we're doing around metabolism. Can you see my screen okay? Is it?
Yes.
So one of the big questions I get when a patient is diagnosed with a GBM and I have to perform surgery, it's why did I get this? And the second one is, what do I eat? And what I eat to help it to respond to treatment? What do I eat to prevent it from coming back? And what does my family eat to prevent a tumor from being formed? And we don't have the answer to that. We have a great integrative medicine program here that Dr. Sengupta leads, a lot of detail in terms of dietary strategies and life strategies to address this. But it was something I was interested in taking to the lab and trying to investigate. And what we know is that GBM results in a shift in the fatty acids and the lipids that are in the tumor. And so mechanisms that target metabolism are poised to be highly effective. Recently, the World Health Organization changed the classification of gliomas because of the importance of isocitrate dehydrogenase mutations in classifying these tumors. And more recently, vorasidenib was approved as a treatment for IDH and IDH mutant tumors, which just emphasizes how much of a role that metabolism plays on tumor development and tumor progression. And you can see here in the schematic of the layout of tumor classifications that are gliomas. At the top, we see the stratification by this metabolic mutation in IDH. And what we know is that the environment in a glioblastoma is very different. There's components that have a lot of oxygen, and there are components that don't have it or are hypoxic. And then the cancer cell changes its metabolism to adapt to this. And when we look at survival based on these different stratifications of the tumors with the IDH mutations, you look at the big picture, the red and blue, and then you look at the composition of the tumors based on the lipids and amino acids, all the dietary things that go into these tumors. You can see that stratification lines up. And so metabolic restriction in cancer has been well established to have a benefit. And several groups have shown in other cancers and in gliomas that if you target certain amino acids, or even if you do dietary restrictions, you can improve the efficacy of these cancers, the efficacy of treatments for cancer, sorry. And then more recently in pancreatic cancers, one of the colleagues when I was back at Columbia showed that in pancreatic tumors, which is a highly malignant tumor, cysteine depletion can result in improved survival in their model. And so we took the approach of targeting this cell death pathway called ferroptosis, which essentially is an inborn program in the cell to clear free radicals, or these reactive oxygen species that you hear about. And we have certain drugs that can target it, and they work pretty well. And we did a study in mice and tumor cells. It was published last year, that we showed that if you take out the key components of this pathway, you can make the glioma cells very responsive to a treatment, and even just with the diet alone, the tumor cells die. And then when we look at the metabolic makeup of the tumors treated with the diet that was low in cysteine and methionine, and the ones that were on a normal diet, there's a dramatic shift in the two profiles. You can see the separation here, and then a heat map with the red and blue showing that the composition of the tumors changed dramatically with just the dietary treatment. And so what we did, we took mice that had the tumors implanted in their brains and put them on the different diets. And we saw in the blue that the mice on the CMD diet with low in cysteine and methionine did significantly better. And then when we combine that with a drug that targets that pathway, they had the best overall survival. So what we want to do now is take this to patients, which is always our goal. And so we're developing a phase 1 study here at UNC that we hope to launch in the near future, where patients with recurrent glioblastoma can be initiated on a similar diet designed specifically for patients to see if we can see these same signature changes that we saw in our preclinical studies in the mice and in the cells that suggest that the tumors will respond to the treatment. What this will also allow us to do is to determine when's the best point to come in with another therapy that the combination may be very robust. The benefit of this is that it's not lifelong diet. We want to do something that essentially goes along with the treatment that is planned for a short period, so that after that period is over, regular diet can resume and you can enjoy the things that you like to eat normally. What we also hope to gain from this is how can we do molecular imaging to determine not only the response to the treatment, but also the tracking the tumor progression. We heard some of the studies that the importance of tracking the cytokines and detecting changes in the blood-brain barrier to be able to know when this tumor is growing back. And so we plan to use molecular imaging techniques to be able to track this. So similar to what Dr. Dome showed, this is a patient with a glioblastoma near an eloquent area. We do the resection, but we know invariably that the tumor will come back eventually. And then preclinical models have shown that you can do these molecular imaging studies to track different molecular tracers that may be able to tell you before the imaging shows when the tumor is growing back. So as I mentioned, the next step we want to do is also determine the molecular changes that occur so we can determine the optimal timing, and then also identify this metabolic signature so that we can know what's treatment effect versus when the tumor is actually growing back. And then what we want to also do is determine the sensitivity of these post-treatment recurrent glioblastomas to novel treatments. And in collaboration with one of the labs here at UNC, with this organotypic brain slice culture, we can take patient samples and in the lab screen them for response to drugs and some of these novel treatments that we're designing to get a sense of whether or not they would respond clinically. So in conclusion, dietary interventions are a promising strategy for treatment, both acute and chronic. Molecular imaging may be a helpful tool to non-invasively track true tumor progression in response to treatment. And then these preclinical screening tools that predict response to novel treatments warrant further investigation. And I'd like to thank the funding sources that we have, and then the rest of the team that have done the work, and take any questions that you have.
Thank you very much, Dr. Higgins. And with that, we would like to open this panel up for discussion and questions, and also take questions from the audience. If I could, first of all, discuss with Dr. Nadoom regarding the cytokine microdialysis work that he's doing. Where are you in terms of the trial, and how many patients are you hoping to accrue for this study? If you could let the audience know.
You may have had to step away. Is he here?
Yeah,
Okay.
so I will move along because he's Dr. Nadoom is on call, so he might have stepped away. There's a question from the audience. Does GBM cancers have anything to do with hereditary? Would a member of the panel like to take that?
So, generally it is not, you don't get it from anybody. You're not going to pass it on to your children. If you have glioblastoma, you don't need any genetic testing. Your family members, siblings, parents, children, nieces, nephews, nobody needs to be tested for glioblastoma. There's some very, very rare syndromes where patients have an increased likelihood to have a lot of other cancers, and brain tumors are a part of those tumors that they can have, but in the general, which is very, very, very rare. But in the general population, the answer to that question is no. You're not going to get it from anybody. You're not going to give it or pass it on to anyone.
Thank you, Dr. Rauf. And with that, I'd like to ask you a question regarding the CAR-T trial that you have open currently. If patients are interested, bearing in mind patients and patient families are listening in, how can they get in touch with you for the study?
They can get in touch with us through clinicaltrials.gov. Our emails and phone numbers are listed there. Our clinical trial is also listed on the UNC Lineberger website, on our Department of Neurology and Neurosurgery website. And those are the best ways to get in touch with us.
Thank you, Dr.
sorry.
Rauf. I see Sharon Isaac in the attendees raising her hand. Do you have a question for the audience, from the audience? Sharon Isaac, you're on mute.
Sorry about that. Can you hear me?
Yes.
Oh, sorry about that. Thank you for all the information. I have a 23-year-old who was diagnosed last September with a DIPG. Just wondering if any of the doctors have anything at their institutions that are working on any of that. She did a focused ultrasound trial, this analysis trial, and the trial shut down. And she's currently in another trial, but just seems there's not much.
Dr. Rauf, would you like me to take that one?
Sure, yeah.
Yeah. As Dr. Rauf mentioned, the clinicaltrials.gov would be the place to look for trials. But in addition, diffuse midline gliomas and DIPGs, they are sort of super specialized, and they tend to be found more in the pediatric population. So places like St. Jude's, UCSF, they have a number of studies, and it's a question of looking into those to see if something would be appropriate for your loved one. And I'm sorry to hear about that.
Thank you.
Yeah, I mean, just to add to that, we have a clinical trial that's using CAR-T against pediatric brain tumors that is not up and running yet. I think we are 1 year away from having it up and running.
One of the CAR-T trials, right? Is it the same as the Seattle trials?
In a lot of ways, it's similar.
Yeah.
Yeah.
Okay.
Okay, thank you.
Thank you. And with that, Dr. Rauf, Ms. Isaac has asked a very useful, question. Similarity between CAR trials, the two that were recently published. Can you explain the sort of specificity and how these trials can vary for the patients and the families?
Right. So, it's really interesting. The two CAR-T clinical trials that are published and the one that we're running here at UNC, all three of them are targeting a different target. So the one at MGH targets EGFR. The one that was published by the City of Hope targets interleukin R alpha 2 receptors, and the one we are doing here targets B7H3. All three are phase 1 clinical trials, and the main goal or the main objective of these clinical trials is to look at safety and tolerability. And both the trials that were published have shown that that CAR-T against EGFR at MGH and against interleukin R alpha 2 receptor at City of Hope are safe. And at both those places, they did not see any dose-limiting toxicity, which is promising because that's what we want to see in a phase 1 clinical trial. We want to make sure that it is safe to be given to patients that have glioblastoma. The MGH clinical trial, the only information I have is what was published in their NEJM paper, and they published information about the first 3 patients that were enrolled on that trial. Looks extremely promising. The interleukin R alpha 2 receptor trial at City of Hope, they published results from 65 patients, and that showed that they had 5 arms, and in one of their arms, the overall survival was 10.2, which is higher than what we have seen in some of the other trials for recurrent glioblastoma. Having said that, these are all phase 1 clinical trials, and They're all extremely promising, and we will know more once they go on phase 2 and phase 3.
Thank you, Dr. Rauf. I'd like to question Dr. Higgins as well. There's actually a question from the participants, and also it leads nicely into your metabolism aspect of your phase 1 study. Why do we wait until recurrence for most trials, as we know GBMs will inevitably come back? And piggybacking onto your phase 1 trial, do you think the metabolism element is important here?
Yeah, I think that's a great point. And we were recently at a conference and discussing that there needs to be a paradigm shift in terms of how we manage these tumors. The watchful waiting strategy is likely not the best. And so you have things like focus ultrasound that improves the ability to detect changes that were previously undetectable in the brain environment, or delivery of things like CAR-T that could potentially keep the tumor at bay. I think these are great strategies that we can implement in the post-resection, post-initial treatment, or even upfront setting. What we would need to do, though, is to understand what's happening in the tumor in this period. And so one of the big efforts in the lab is to understand in models of tumor recurrence, to recreate that environment of the tumor metabolome after it's undergone resection, after it's undergone radiation and chemotherapy. What are the signature changes that we see that will predict this is the time when the tumor is growing back, or this is the time when it would be best to come with a second treatment? Because if we have the tools to detect the metabolite changes, we need to know what they are first. So once we have that, I think with all these technologies put together, hopefully we can have earlier intervention before we see actual recurrence.
Thank you very much, Dr. Higgins. So the next question is for Dr. Krishna. In terms of the trial opening, how can patients get a hold of it, and what is the timeline for the trial opening?
Dr. Sengupta, the trial is open for recruitment, and similar to what Dr. Rauf mentioned, this trial can be found on clinicaltrials.gov. The short code for this trial is BT015. It's a pivotal trial of blood-brain barrier disruption and liquid biopsy in subjects with glioblastoma. Information is also available on the website, the Neurosurgery website at UNC.
And if patients and their families are interested in it, is it also for recurrent patients, or is it for newly diagnosed? Is it for both? Could you specify?
Yes, it's a great point. So it's for both suspected glioblastoma and suspected recurrent glioblastoma, both.
Excellent. And what makes you excited about the study? Is considering cell-free DNA and circulating tumor cells are also highly topical.
Can you clarify, Dr. Sengupta, about topical?
In other words, there are it's a very hot area of research now.
Yeah, so the idea becomes that you could do long-term surveillance of tumors and understand the biology as these tumors change over time, as you saw in slides Dr. Najm showed, where the tumor came back after 16 months. What changed in the biology of the tumor, and how do you do the surveillance? And the most exciting part for the trial is that you could do that in an incisionless way, so that you can make more informed decisions about the therapy for these patients, potentially even personalizing the treatment based on some of the changes in biology, for example, mutations that you see in these tumors. The other aspect would be that while you open the blood-brain barrier temporarily, whether we could also then pair it with increasing the penetration of chemotherapy in a very conformal way, a targeted way to these brain tumors. So these are two related aspects of the trial that we are excited about.
And do you think that could decrease toxicity of these agents potentially?
Yeah, that's a great point, Dr. Sengupta. That remains to be seen, but certainly is a big motivation for undertaking these trials. And so if you were to open blood-brain barrier and increase the delivery of the tumors, the chemotherapy to the tumors, then potentially you could use less dose and avoid side effects that are related to higher dose in other body areas. And so, yes, that's a motivation, and certainly remains to be seen as to how it pans out in clinical trials.
Great. Thank you very much, Dr. Krishna. And with that, I just would like to ask the participants whether they have any further questions. And if not, I would like to close the sessions, but I would just like to give a few seconds to make sure that there are no burning questions from anybody else. Okay, I do not see any additional questions. And with that, I would like to thank each of the panelists for their excellent talks and for bringing various dimensions into the landscape of brain tumor trials, and thanking the Brain Tumor Foundation for their generosity and their diligence to patients and their families in hosting this event. And I believe this InfoCon is recorded. So with that, I would like to wish everyone a good evening from this end, and thank you for joining us.
Thank you.